Okay, as I was saying, I am grateful to Dr. Elaine for her lecture. And what I was saying, that the epilepsy is a very old disease, is going to 3,000 maybe years, 3,000 years ago. And the first description about disease was found in the Papalian in Iraq. And this is what they're writing here. And the word epilepsy itself means start from epi, means upon, like epidermis, means covering the dermis, or epidural. Lepsia in Greek means seizure, as taking possession of. As you said, the police take the seize of the thief by his neck. In the old days, they were thinking that an evil go inside the patient and start him to be shaking. So the solution was to dig a hole in the head of the patient. This was the concept until Hippocrates came and he said, this is nonsense and this is a disease. Also, Avicenna, in his very great book, the Alcanon, wrote a chapter about it. So epilepsy is the tendency to have a spontaneous recurrent seizures. And the key point is tendency, spontaneous, and recurrent. Seizure is any clinical event caused by an abnormal electrical discharge in the brain. So having a seizure does not mean having epilepsy, because epilepsy means chronic neurological disorders characterized by recurrent seizures, but the seizure is a sudden uncontrolled electrical disturbance in the brain. The epilepsy is not very rare. It affects about 3% of the population. Now we come to the classification. The epilepsy is divided either it is started in one part of the brain, which is giving the electrical impulses, and this is called partial, or started in the thalamus, which we call it the pacemaker of the brain, and it affects the whole brain. The seizure is classified into focal, or generalized, or unknown. The focal subclassified either about the awareness. If it is unimpaired, they call it simple, and if it is impaired, they call it complex. And it might be motor onset or non-motor onset. The motor, usually automatism, tonic, clonic, myoclonic. The non-motor is sensory, emotional, and autonomic. Sometimes it started as a focal, and there is a secondary generalization. The generalized onset, it is divided into motor and non-motor. The non-motor is the absence, and the motor is myoclonic, tonic, clonic, and other motors. The seizure has a pattern and characteristic that it is a stereotypic, it is rhythmic, it is brief, and its feature depends upon the site of the brain which it emerged from. Some symptoms, it's in the focal, and it's very important to recognize these symptoms. Will come later on when we talk about non-convulsive states epilepticus. We need to look after the staring and the unresponsiveness, confusion, picking or lip smacking, jerks and twitches, shaking and wandering. In the general, you started by a trigger like flashing of light. We have the aura, which is a focal seizures, and it depends upon the site of the brain which start the seizure. And then we have the ictal phase with the tonic, clonic, and then we have the post-ictal phase with the confusion and hallucination. We have the partial. If it starts in the occipital, the patient will have a visual hallucination. If it starts in the sensory area, the patient will have a tingling in the contralateral limbs. If it starts in the motor area, there will be the Jacksonian fit. If it starts in the temporal area, there will be ringing. And if also in the temporal area, where is the limbic system, the patient will have déjà vu, jamais vu, sweating, flashing back. And this is the normal brain with the normal EEG. If the fit in the temporal area, the EEG will show here. And if it's general, the EEG would be generalized abnormality. Now, how to diagnose epilepsy? This is just a joke. I already did, because we have many patients, they self-diagnosed by the net. We diagnose epilepsy according to the ILAE, is that at least 2 unprovoked seizures apart by 24 hours. If the patient fulfills this criteria, he is epileptic. Or if the patient have 1 seizure plus high probability recurrence. So now, what are these high probability recurrence? If the patient has developmental disorders, if he has a neurological exam abnormality, if he has a trauma with loss of conscious but normal imaging, if he has abnormal brain MRI, if he has abnormal EEG, if he has a seizure from sleep. These are the factors which push us toward the diagnosis of epilepsy and starting treatment. The pathophysiology is very important. To understand the epilepsy, we need to go back to physiology. That is very important to treat and understand what is happening. And we have a choice. We need to go the hard way. So we go to the physiology. We have the neurons, they have the dendrins. The impulse comes from here and goes through the axon, which is covered by myelin. And this is the nerve, not the nerve, to make it more accelerated until the synapses here. When the axon come here, it doesn't contact to the dendrits, there is a gap. And this gap is called synaptic gap. We have here, we have a chemical gap where this is the impulse comes here in the presynaptic. These are the vesicles of neurotransmitters. The impulse come here electric, it cannot cross to the postsynaptic. It cannot cross to the postsynaptic. It needs that neurotransmitter to make it comes back here and then continue with the journey. So these are the neurotransmitters, and we have, as it's coming, we have a neurotransmitter which is excitatory, like glutamate, and inhibitory, like GABA. We have also the chemical, the electrical gap, where from presynaptic, it goes in the gap junction from here to here. Now, we have, this is the axon here, and from here, and this is the second neuron. We start from here, from a neuron, and the second neuron, to the impulse to go from here to here, you need a neurotransmitter. So from electrical transmitter here to electrical transmission here, you need this. And this is the neurotransmitter. So it can, so the electrical impulse can go to the postsynaptic. And this is a very, very crucial concept, and depends on it, treatment of epilepsy. In the normal physiology, we have the potassium in extracellular is 4.5, and in the intracellular 160. So there is a lot of difference here, and the equilibrium is minus 95. The sodium is more outside the cell and less the inside the cell. We will know why God created this when we'll go further. Now, when the impulse come here, normally the cells, if you put a galvanometer inside and outside the cell, it is negative inside and positive outside. It's negative in the nerve, -70. So when the impulse come here, there will be influx. The sodium enters in the cells. So the electrical activity and the electrical impulse is more positive inside the cell. It goes from here, from -70 up here to 30. Positive, from -70 to +30. When it reaches the 30, the sodium channels will close automatically. And after that, the same time, and maybe in the same time, the potassium start to leave the cell. So the cell become more and more negative and it reaches here. But because the sodium channels closes quicker than the potassium channels, it will take time and even comes down. And this is hyperpolarization and then come back. Once they reach here, there is the sodium potassium channel bump, it will correct the things. We have it here again, which is similar. This is the cell and this is the outside. The outside is positive, the inside is negative. And once there is depolarization, the sodium comes inside the cell. So the inside the cell become positive. It was negative here, it become positive, and the outside negative. Then a repolarization, the potassium start to go out. So the cell become negative again. And after that, the sodium potassium pump will restore the things, will take out the here again, the sodium channel activated. This is the resting membrane potential. This is the impulse. The sodium goes up until 30. And then after that, the sodium channel deactivated and the potassium channel activated. So the potassium will go out from the cell and the cell electricity become less and less and less and less until it reaches the resting membrane potential, and even that there will be hyperpolarization. So again here, depolarization and potential. This is very important. So this is after hyperpolarization. This is very important in treatment. So now this is the sodium potassium pump. What it did, it take 3 sodium out from the cells to the outside and bring 2 potassium, 1, 2, inside the cell. Now, the brain, the God created as there is 2 opposite factors, as it is in anything, sodium, potassium, sympathetic, parasympathetic, everything has it is contradiction. There is excitation, which is using a glutamate and aspirate, and there is inhibition, which uses GABA. And they are balanced. This is in the normal brain. They are in balance. In epilepsy, the excitation is increased and inhibition is decreased. This is the glutamate and this is the GABA. There's no much difference actually in the structure if you see it here. Now, so normally is composed from excitatory, which is the green, and inhibitory fibers, which is in red. In epilepsy, you have more excitatory than inhibitory. So excitatory are upgraded and inhibitory are downgraded. This is the problem of epilepsy. So now we know the problem. A problem will describe it, as Einstein said, is a 50% solvent. So we need to increase the inhibitory and decrease the excitatory. Simple as that. Now we have two neurons. This is a neuron which is excitatory using the glutamate and causes the sodium to go in and calcium to go in. We need calcium to start. Back to the physiology, the impulse comes here. It causes the calcium channel to be activated. The calcium goes in, causes the vesicle, which is filled by glutamate, to adhere the presynaptic membrane and evacuate its neurotransmitter, which is glutamate in the synapse. And this causes the sodium channel to open and make the impulse, the electrical impulse, to pass from presynaptic to the postsynaptic. On the same time, we have the inhibitory neuron, which cause the GABA, to adhere to the membrane. And when the GABA comes, it causes the chloride, which is by -2, go inside the neurons. Sodium will cause excitation, chloride will cause inhibition. And this is the picture. So now we know what's happening. So what we do, we decrease axonal conduction by preventing sodium influx through the sodium channel. And this is done by carbamazepine and phenytoin. We reduce the sodium going in by carbamazepine and phenytoin. We also increase the inhibitory tone by facilitation of GABA by barbiturate and benzodiazepine. We facilitate the GABA by increasing by the barbiturate and benzodiazepine. Also, we decrease the excitatory effect of glutamate by lamotrigine, tobromide, and filbamate. And we decrease presynaptic calcium influx through type T channel in the thalamus. We do it by etosuxamide and valproate. We reduce calcium, presynaptic calcium, to influx by the etosuxamide and valproate, because calcium, when you go in, when you activate it, will cause the glutamate to adhere to the presynaptic membrane and cause the sodium channel open and propagation of the electricity. Now, for the treatment, we have the excitatory synapses and inhibitory synapses. We have the voltage-gated sodium. It is blocked, and we call it membrane stabilizer by phenytoin, carbamazepine, oxycarbamazepine, lamotrigine, locasenamide, zonisamide, and we have also the calcium channel blocker by the pregabalin and gabapentin. We have the GABA, increasing the GABA by the pregabalin, and we increase the GABA receptors by benzodiazepine and phenobarbital. So now, what are the definition of the status epilepticus? There is the traditional definition, which uses more than 30 minutes, and this is include the recurrent seizures without returning to cognitive baseline. That was the definition before, but they found by 30 minutes there will be a brain damage by that time. So now the new definition, which we call it operational definition, or embedding state epilepticus if it is more than 5 minutes. We have another definition for status, refractory status epilepticus, when the seizures fail to control by adequately dosed benzodiazepine and one of the second-line anti-seizures medication, like phenytoin or levetiracetam or whatever. We have subarefractory status epilepticus, which is continuous status epilepticus beyond 24 hours, requiring coma induction. So this is subarefractory. Coma induction, we use midazolam, barbiturate, propofol, and continuous infusion. The seizures of status epilepticus are divided into generalized convulsive and generalized non-convulsive. We have also focal impaired awareness and focal motor states. According to the ILAE, there is a definition also that according to the type, if the seizure is tonic-clonic, the time is 5 minutes. We need emergency treatment should be started at least, at most, 5 minutes. If it is generalized, if it is tonic-clonic. And we started to expect trouble if it is continuous for 30 minutes or more. But if it is focal impaired awareness or absence, it is less sinister, and we need to treat it at maximum 10 minutes and 10 to 15 minutes in the absence. And we need in the focal impaired awareness, we expect to have problems if it is lasted more than 60 minutes. So the key point, treat as soon as possible. Non-convulsive status epilepticus is a persistent change in mental status from baseline, lasting more than 5 minutes, with epileptiform activity seen in EEG monitoring, and subtle or no motor abnormalities. This is very important because the patient is not convulsing. He has only persistent change in mental status. And we see it, some EEG findings. So what are the features we need to look for in a patient who is in non-convulsive? We need to look for the altered mental status. 80% of the patient will have it. They will have confusion, coma, memory loss. There might be speech disturbance. There might be myoclonus. There may be unusual behavior, maybe an anxiety, agitation, and hallucination. Any patient, we are not sure what is the cause of his decreased mental status, after excluding the 3 big causes, which is a structural, like CVA or subdural hematoma, or infection, meningitis, encephalitis, maybe UTI, or metabolic, we need to consider non-convulsive status epilepticus in this patient. Also, there are subtypes of non-convulsive status epilepticus. We have simple partial. There will be focal status epilepticus without impairment of CNS. There may be hemiparesis, hemispatial negligent. EEG is variable. It might be complex partial with impairment of consciousness. It might be temporal loop. There will be fluctuating of conscious, irritability, aggression, and automatism. Maybe frontal loop type 1, which is unilateral form with affective disinhibition, because the frontal loop is controlling the cognition. effective disinhibition and emotional liability. Frontal lobe type 2, which is bifrontal form with confusion and altered mental function. Might be absence. There is also generalized non-convulsive status epilepticus. We need to consider it in prolonged alteration of mental status or altered behavior and slow speech or abnormal movement of eyelid or perioral movement. There, we need also to be vigilant in a patient with coma, which is seen after convulsive state, and he has no convulsive activity and may show myoclonus or nystagmus. We need to keep our eyes open about non-focal status epilepticus. Now for the treatment, the therapeutic goal is maximizing seizure control while minimizing adverse drug effect. That's our strategy. So now to treat or not to treat is the question. Like Hamlet, to be or not to be, that's the question. We need to consider many factors. If we treat, if we don't treat, we should consider the injury like sudden and unexplained death. We need to consider the cognitive decline and suicide. We need to consider the social stigma and the restriction of physical activity. For the medication, if we treat, we need to consider the disequilibrium, which is caused by drugs. We need to consider the cognitive slowing. We need to consider the weight change, increased by the sodium valproate and decreased by topiramate, and organ damage. We need to consider the side effect of the drugs like Stevens-Johnson syndrome, which are caused by lamotrigine, phenytoin, carbamazepine, phenobarbital. We need to consider the marrow failure by the carbamazepine. We need to consider the depression psychosis by levetiracetam. We need to consider hyponatremia by the carbamazepine and visual field effect by vigabatrin. All these factors we need to consider when we are deciding to treat the patient or not. So the side effects again here. Now, how we start? The rule number one is to start low and go slow. Never started anti-epileptic treatment with a big dose, because if the patient develops side effect, he will never touch this medication again. And by that, we lose one of the best weapons we have. We need to consider seizure type and anticipated side effect, comorbid condition, drug interaction, and cost. Now, treatment of epilepsy started since 1910 by the phenobarbital, and now in 2010, we are ended by cannabinoid. The anti-seizure treatment, 60 to 70% of people have controlled seizures, thank God. Unfortunately, 30 to 40 people have uncontrolled seizures. Now, if we track the patient newly diagnosed, 47% will be seizure-free, and 53 is not controlled. From this 53, if we add another drug, we try another drug, second, 13% will be free, but 40% will not. From this 40, If we have a third drug, only 1% will be free and 39 will not be free. Now, what are the risks of status epilepticus? It's a brain injury. You're talking about time is brain. The earlier you treat, the earlier you preserve the brain. Studying children with ICU shows that many studies have correlated an increase in EEG seizures burden with poorer outcome. But the key point that rapid treatment of seizure does not improve the long-term clinical outcome. Because when we have a patient with a brain injury, he will have disability. But if he developed seizure, the seizure itself, it will cause disability. So the cause is important. Now, what is the complication of the status epilepticus and its treatment? One of the complications is a low blood pressure, because when you induce a child or adult into coma, you need a medication to make their blood pressure up. The other complication, infection. 60% of children on pentobarbital, they will develop pneumonia. Sepsis increase risk in hospital death, because if you put the patient to sleep in coma, there will be increase in infection and increase in sepsis. Metabolic acidosis, because if there is hypoxia, the patient will start to burn his fat and cause metabolic acidosis. Respiratory aspiration, sometimes the patient will have vomited, or his fluid or saliva will cause aspiration, and there will be lung injury and prolonged mechanical ventilation. Muscle breakdown, if the patient's status will be on his back, and there will be destruction of the muscle, which leads to a release of myoglobin, which blocks the renal tubule, causing rhabdomyolysis and pancreatitis. Now, mortality of the refractory status epilepticus, that's what we did, the worst of the worst. The patient is not responding and have 24 hours and have to be put on sleep. Most of the mortality is 30 to 50%. And most important factor is the underlying cause. If the patient has congenital abnormality or cerebral palsy, that's the very important cause as due to acute injury. Major medical complication, the patient developed renal failure, respiratory failure, and withdrawal of intensive care support. Morbidity, there will be high in survivors, and of course, most important predictors. Now, if you see here, if the patient is treated less than 60% days after status epilepticus, and this is the percent of mortality, and you see here in the more than 60 minutes up to here, up to 30% and less. Now, what are the complications? The patient can aspiration pneumonia, pulmonary edema, lactic acidosis, shoulder dislocation, rib fractures, cardiac arrhythmia, and rhabdomyolysis. This was pictures of Dravet syndrome. This is the normal brain, and this is an edema of the brain. Also here, if you see, this is the brain of a patient with status epilepticus, and you see there is a hyper intense areas in the brain when this is the hyperintense area in the gray matter here. This is also, this is in the acute stage. You see, this is half of the brain is decreased attenuation, and this is in the chronic. So basically, the long-term outcome of the critical assessment, this is articles published in Epilepsy that they reviewed 37 studies reporting long-term outcome after status epilepticus in a pediatric and adult. They considered the length of follow-up and outcome measures, investigated mortality, status epilepticus recurrence, subsequent epilepsy, cognitive outcome, functional outcome, and the quality of life. And the predictors of long-term outcome are overall risk for a long time is high, both in children and is the main determinant outcome. They said that the risk of long-term outcome is high in both children and adults. Etiology is the main determinant. Etiology is the main determinant of the outcome. So the etiology is the number one. So management, if you have, which is give oxygen, both and cannula, stop it, we give diazepam, 10 milligram, or lorazepam, and we take a blood. We support the patients, and we, if still fitting, we give another 10 milligram, otherwise you transfer to ICU. We start phenytoin. This is in Libya, 20 milligram per kg at 50 milligram under ECG monitoring. If still fitting, intubation, ventilation, and general anesthesia. Our policy here in Libya is going to be up to date. We divide the patient. If the patient is hemodynamically stable, we give phenobarbital 20 milligram per kg at 100 milligram, then pentobarbital 10 milligram per kg at 100, additional doses till seizure stop, and the burst suppression pattern appears in EEG. This is the burst suppression. There is high voltage spikes and waves here. There is an isoelectrical line, there's decrease, and then this is, when we see this is a burst suppression pattern. And we continue the pentobarbital for 24 hours. If it's unstable, we use midazolam, 0.2 milligram per kg, and if persists after 45 minutes, we go propofol and pentobarbital. If the patient high risk of pulmonary failure, like somebody with a chronic obstructive airway disease, we started by propofol immediately and controlled. Now we go for the there is as the most of the patient are in ICU are non-convulsive, and as prolonged EEG monitoring is labor intensive, quantitative labor intensive, and you need to review a very long strips of the EEG. The quantitative EEG invented to help us. So this is a quantitative EEG. This patient is 2 hours of quantitative EEG. He has 15 seizures per hour. The red ones are the machine give us whenever there is a seizure. The patient has non-convulsive status epilepticus. And after that, after giving, this is before giving him IV, and after giving him IV phenytoin load, and you see the fits are stopped. So it's very useful, this quantitative EEG machine. Why we need to treat status epilepticus immediately? Why? What happened that we have the GABA receptors with the inhibitor are located in the surface of the neuron. These are on the surface. When the medication like benzodiazepine bind to the cells here, the cell become hyperpolarized and less excitable, as we said before. But when there is a status epilepticus causes the GABA A receptors to internalize inside the cell. Thus, when the benzodiazepine comes here, there will be no GABA A receptors, so the benzodiazepine does not work. We have here, this is the baseline. We have the presynaptic neurons. We have the GABA receptors, which is the green. We see there is 5 of them. And we have the N-methyl, the aspartate receptors, which is the receptor for platinum 2. Now, after prolonged seizures, what happens? The GABA receptors become less. And when it is less, the benzodiazepine will not find the receptor to work in, and the status epilepticus will continue. There was a very interesting research done by Dr. Cooper in animal, in model animal. What he did, he stained the GABA receptors by the green. So now this is the normal, all green here. The GABA receptors are green here. And he's taking the time 10, 20, 30, 60. And when there is, this is when it is normal, and when there is a fit, it becomes red. And this both, if there is GABA, is internalized or not. This is when the gamma is internalized. You see this, it becomes less and less. This is the normal GABA, which will be benzodiazepine attached, normal, and this is the GABA in the surface, and it comes down inside the cell. So this is not working because it is inside the cells. This is in the surface of the cell. So the message that when the status epilepticus become worse, you see this is in the 0, at 10 minutes there is still there, but when it is 30, 45, and 60, there is no GABA. So this is what we call window of opportunity. We need this to treat here so the patient will not go to death. There is a trial of 3 anticonvulsant medication of status epilepticus, 384 patients, children and adults. They give levetiracetam 60 milligram, they give phosphophenytoin, and they give valproate. And the result, absence clinically evident seizures and improved response. It was 47 in the levetiracetam, 45 in phenytoin, and 46. So basically, they have the same efficacy. Can the status epilepticus be prevented? Not always, but all persons need a home rescue medication. All persons need a rescue plan to outline treatment if home rescue does not work. So home rescue, we give them midazolam basal, nasal, diazepam rectal, buccal and nasal, lorazepam and clonazepam oral distinguishing tablet. Most commonly used option, there was a survey with the US pediatric epilepsy. Most commonly used options belong with seizures, diastate, which is a Valium, rectal Valium for younger children and infants, and nasal midazolam for all others. This is the most common drug used, which is a rectal diazepam by the US pediatric epilepsy. If there's a clusters of seizures, we use diastase, which is a rectal Valium for infant and severely delayed, and clonazepam. Now, the dosing is according to weight of the children. And now, what is the definition of the refractory epilepsy? Is failure of an adequate trial of two tolerated, appropriately chosen and used anti-epileptic drug schedules to achieve sustained seizure. Yani the definition is two drugs should promote a comprehensive review of the diagnosis and management, preferably by epilepsy center. If it is reviewed by epileptic center by expert in epilepsy and we fail by two medication which are used appropriately, we go to the surgery. And the brain surgery for epilepsy is old since long time. So now, what is the indication of surgery? Intractable focal epilepsy, unilateral seizure focus, no significant psychiatric or other medical condition, surgical accessible epileptogenic zone, MRI identified abnormality, improves outcome. These are, we subject our patient to surgery. So how we evaluate them? We do MRI to define the focus. We do video EEG monitoring to localize the seizure. We do neuropsychological testing, identify and localize memory abnormality. We do PET scan to identify the hypermetabolic region, because during seizure, the area which have focal abnormality will take more glucose, and some we do water test. This is to see where is the speech center and memory difference. So this is intracranial EEG. The surgery is lesionectomy or loopectomy or corpus callosum or functional hemispherectomy or multiple subbile transection. And we see here if the patient failed, there is 58% without seizure. Only 8% will be without seizure, but with surgery, you're talking about 58% improvement. I enjoyed talking to you, and thank you very much.
Thank you so much.
Thank you.
Dr. Al-Sadiq.
Thank you.
Our audience, we have a Q&A chat where you can send in your questions and they will be answered. Right now, I want to introduce our panelists. Professor Ehab Shaka from University of Cairo. He has more than 22 years of experience and expertise in neurology with expert opinion in epilepsy. So he'll be giving us some of his comments regarding status epilepticus and epilepsy in general. Thank you, audience, and you are welcome, Professor Elhab. Thank you.
Thank you, Professor Martin, for this nice introduction. And thank you very much, Professor Siddiq, for this very elaborative lecture. Of course, status epilepticus is one of the challenging neurological emergencies. I have a few challenging points to address and share with you. I always think about exactly as you kindly and you have noted in your lecture that time is brain, and waiting any delay in managing the status will bring intractability. Because of the receptor trafficking and the internalization of the GABA receptors. That's why I strongly recommend for our junior resident and or the first encounters in the emergency department. Sometimes patient arrive to the ER and until then, he did not receive any medication, either because of the lack of emergency medical services, and the family are the one bringing the patient. So I advise you all, this is the practice I encourage, to give midazolam, which is water soluble and does not need to be given IV. It can be given intramuscular or even buccal or nasal. The same preparation that is present as ampoules can be given, can be broken and given in the mouth of the patient, or can be injected by needless syringe into the nostril of the patient. Why? Because time that will be consumed in getting a cannula in place to give IV benzo will invite intractability. When a study was done between lorazepam and midazolam, they did not find any IV lorazepam and buccal or nasal midazolam, or even intramuscular midazolam. They did not find any difference in seizure control or status termination between these two drugs. And they found that lorazepam, of course, IV has a rapid onset of action than midazolam intramuscularly or nasal or buccal, but the time needed to get the cannula in place was nullified the benefit of lorazepam or the faster action of lorazepam, because midazolam was given earlier than lorazepam, although it will act a little bit later than lorazepam. Lorazepam was delayed because of the time needed to fix a cannula in place. This is one of the points I want to share with you. Even sometimes we see patients with intractable epilepsy and they are prone to status epilepticus. I give the patient, the relative, one ampoule of midazolam and tell them when the patient will break the 5 minutes of seizure, please, before coming to the hospital, please give him either intramuscular if you have the skill of giving intramuscular injection, or empty the ampoule into the mouth of the patient or the nose. This decrease the likelihood of the patient being into refractory status epilepticus. I don't know the practice in Libya does, or in Uganda does it allow dispensing such medication, because of course midazolam injection is a hospital drug. So we have the in Egypt we can, if the medicine is written on a prescription, the patient can get the medicine from a certain pharmacies. This is one point I wanted to share with you. The other point is I always in managing status epilepticus tell our colleagues and residents to think about the etiology, especially if the patient has no obvious cause for the status, because this patient presenting with status can have any kind of abnormality, can have herpes encephalitis, can have an acute stroke, and that is masked by the ongoing seizure activity. So always try to think about the etiology. This is one of the points that sometimes is neglected in the face of the patient seizing and managing the status. Sometimes is governing the situation, and we forget about the etiology. Especially, of course, you are aware about the NORS, new onset refractory status epilepticus, and a portion of these patients turned out at the end of the day to be autoimmune encephalitis, and if the patient was given maybe steroids, pulse steroids, or plasma pheresis or IVIG, maybe it would have cheered in, helped in managing the status, exactly as a patient with herpes encephalitis, hand in hand with the managing of the status epilepticus. If he is giving Zovirax, he will do far better if the drug is started early. That's why, again, I strongly encourage, because in status epilepticus, sometimes the transfer of information is not that accurate. The ICU resident will see the patient. Sometimes he has no proper history, and when he has a history from the family, yes, this patient 3 to 4 days before his status had some hallucination, has some headache, had some manifestation that will point you that a process was ongoing before the patient presenting finally with the status epilepticus. Also, because Professor Siddiq beautifully noted the hemodynamically unstable patient. That's why also I advise all patients with status epilepticus, when they are presented to the ER, to have 2 cannulas in place, not 1 cannula, exactly as a patient who has acute stroke, so that one line will be dedicated to the medication, and the other line will be dedicated to any hemodynamic drugs the patient might need. He might need a levofed infusion because of hypotension. This patient who has hypotension present a great challenge in managing, because all anesthetic drugs, benzodiazepine, phenytoin, and later midazolam if the patient and propofol. All of these will cause hypotension, and the patient will probably need some form of hemodynamic support like levofed. Also, very important to address the metabolic factor the patient has, because correcting a metabolic factor like hyponatremia, like renal impairment, will greatly share in managing the status. Metabolic acidosis usually is not that severe to mandate therapy, and I always keep the residents away from bicarb injection, because when they find metabolic acidosis, they are eager to correct it. But acidosis, as you recall, is an anti-epileptic strategy. You are aware of the ketogenic diet and its role in managing epilepsy. So a mild acidosis might benefit the patient in these stages, and we do not usually manage it unless it is very severe, and it corrects usually spontaneously when the status is managed. Another challenging point, Professor Siddiq also noted in his beautiful lecture, is when the patient present to the ER, and then he has no obvious convulsion, he has no obvious motor manifestation. Maybe he has no motor manifestation at all, but did not recover consciousness. And things will be even more difficult is if the patient have received in the way to the hospital, or maybe in the ER, and you see him in the ICU, a benzo injection, and then you do not know if the patient is post-ictal, or is he sedated from the medication he has received, or he is still in electrographic status epilepticus, which we call non-convulsive status epilepticus. This is a real challenge. Nobody can tell you if the patient, this patient is in non-convulsive status, or is he's in post-ictal state, unless AEG is done. The longer, of course, the patient stays comatose, the higher probability that the patient is in non-convulsive status. And it is to be noted that elderly patient take time more than younger patient to recover from status epilepticus if they are successfully managed. That's why EEG here is a mandatory tool, and it helps us in classifying this patient. This patient has been successfully treated, but is in the post-ictal state and he will recover, or he is still in non-convulsive status epilepticus. So doing an EEG is sometimes very crucial in this situation. And even the EEG, I don't want to complicate things more. Sometimes the EEG is difficult to interpret. That's why the American Electrophysiology has made the terminology in the ICU and how to diagnose these patients. It's available free online, and when you do the EEG, you must think about what we call electro-paraclinical gap. What does this mean? This means that the EEG is grossly abnormal. There is triphasic wave, there is periodic discharges, and there is no structural or metabolic factor explaining this EEG picture. Maybe the patient, you are aware of the triphasic waves of metabolic encephalopathy or hepatic encephalopathy when it was first noted is present in metabolic problems. So the patient, if the patient instills epilepticus and he's a metabolic problem and he does the EEG and you find triphasic, and then you are you do not know is this triphasic waves explained by the metabolic factor. If it is explained, then there is no electro paraclinical gap. The paraclinical means the laboratory or the MRI explains the EEG, so the patient is not in non-convulsive. If there is a gap, it means that the patient has no metabolic problem to explain this EEG abnormality, and the MRI does not show a structural or hypoxic ischemic encephalopathy or things like this to explain the EEG patterns, then you don't have a gap, and the non-convulsive status is a possibility. Of course, the main how to say the main benefit of the consensus of epilepsy terminology that was released in 2021 is to be able to diagnose non-convulsive status with the EEG and to protocolize this, because sometimes it's difficult to, as I noted or as I explained, to diagnose patients. The patient has, yes, seizure activity, he has structural maybe brain damage that will reflect on the EEG, maybe he has metabolic problem that will also reflect on the EEG. So sometimes it is very difficult, and the consensus has made a flow chart depending on the epileptic discharge. Are they more than 2.5 hertz, more than 25 periodic discharge in 10 seconds, and you give the treatment and the EEG improves and the clinical picture of the patient improve, then you make the clinical diagnosis of non-convulsive status epilepticus. If the EEG improves, but the clinical picture of the patient does not improve, and then you do not know. You don't know if the patient was in non-convulsive and he is sedated or not sedated like this. You will call it probable non-convulsive status. I think the future will bring the EEG as a mandatory tool in managing this patient. Patient in refractory status epilepticus and super refractory status epilepticus will need at a time point to do EEG to guide further therapy, because when you give these anesthetic drugs, your feedback from the status, which are the abnormal movement, is no longer present, and you have to depend on electrographic criteria before weaning the anesthetic drug. In Cairo University, we try to do a once per day EEG in these patients. Sometimes we are lucky enough if we can do it every 12 hours, but with the resources which are constrained a little bit, we need a technologist, we need the AEG machine to be available. So sometimes in this patient, we do it once in the morning to before withdrawing or tapering down the anesthetic medication. This is my main comments on the status epilepticus. The lecture was very, very illustrative, and Dr. Professor Siddiq beautifully explained everything, and I will give the mic back to Professor Martin.
Thank you so much, Professor Ihab. Right now, we are going to have some question and answer for our panelists and also our presenter, and we have around 11 questions. Some will be directed to the presenter, some will be directed to the panelists. And in any case, if you feel like having any additions or any more comments, please feel free to chip in. So we have a first question from Rahil. I think it's directed to Dr. Al-Sadiq. Any localization for pruritus or itching as an aura in epilepsy?
Thank you for your question. To my knowledge, I am not sure. I am, first of all, I think I should say that I am adult general neurologist. In my experience, I haven't seen pruritus as an aura, but saying that pruritus is abnormality in the sensation, which most probably conveyed by the posterior column, like the vibration sense, and sometimes by the spinothalamic tract. I wouldn't think that we know that the focal epilepsy, which arises in the somatosensory area, it will cause tingling and maybe some numbness. But as pruritus per se, I should confess that I have never seen it, but maybe Professor Ihab, and I have to thank him for his kind words about me. I think he is more experienced in this thing.
Thank you, Professor Siddiq. Pruritus, as you said, probably if it is present, it will localize to the parietal lobe, I think, or maybe it will be some form of automatism. I don't know if the one asking the question, does he see the patient itching himself on the video, or the patient is reporting that he feels, because I think it will differ. If he scratches his skin, I will consider this maybe as an automatism. And the seizure will localize, it will be a lateralizing sign rather than a localizing sign. This is what I can, but as the Professor Siddiq said, I have never encountered this type of aura.
Thank you. There is a second question from Saif. What are the common causes of drug-induced status epilepticus in children? What are the common causes of drug-induced status epilepticus in children?
The question is to me?
Yeah.
Well, I told you I'm adult neurologist. I'm not a pediatric. I haven't seen this.
Yes,
If you
go
allow
ahead.
me, Professor Martin, I think as Professor Sadiq, I deal more with adult, but I think that as regard drug, the most important drug groups in children will be the antibiotics, especially of the carbapenems group or beta-lactam in general. Sometimes in our practice and with residents, they think that carbapenems, imipenem, meropenem, and ertapenem are the only epileptogenic drugs in antibiotics. No, the beta-lactam as a group, including cephalosporins, including penicillins, are all potential epileptogenic drugs that can precipitate status epilepticus, maybe in the at-risk patient. So I think the antibiotics and at an older age, maybe drugs like drug addiction will get into the etiology. But in children, I think antibiotics are an important drug group.
Thank you so much. There is a comment and then a question from Naja Hamza. He's thanking you so much for the lecture, and he wants to know what's the definition of seizure freedom or remission in epilepsy. I think Dr. Al-Sadiq will take on this one.
Well, thank you. Well, our policy, you mean seizure-free, what we do according to the guidelines, that if the patient is a seizure-free for 2 years on drugs, we can stop the drugs. This is what I understand from the question, that when the patient have no seizures whatever for 2 years, we can stop the medication. And if he developed one seizure during these 2 years, the count started from that day. Saying that, there is no guarantee that the seizures will come again. And this is very important. No one can guarantee that the seizures come again. And in my practice, I share with the patient. We have many different patients. For example, I used to have an old lady who has epilepsy, and she is free from seizures for 2 years, but she declined to stop the medication because she will say that I might be having an fit in the supermarket, I will be embarrassed. So she will continue. On the other hand, if we have, for example, an old man, he's playing golf and he don't mind to have a seizure, so he stops. On the same time, I used to have a young man whose livelihood depends on driving. And in UK, the law, according to the ILAE, you have to stop driving for 1 year if you have a seizure. So he said, I'm going to lose my job. So he will continue for a long time. Is this answering the question? This is what I understand from her question.
Yes, I think you've answered the question. It was regarding the when seizure remission and when do you say it's completely to. I think that has been answered. Well, we'll go on to Nuha Hassan, who's asking, how long should we wait between one drug and another to say that the drug is not effective? I think he's asking, when should we switch, or when do you consider switching before What consideration are you making when switching to say that the drug is not effective?
The question to me or to Professor? Yeah.
Any?
Well, for me, when I started the patient, for example, by the carbamazepine, I started to titrate, and I changed when the patient either have side effect or the seizure stops. If the patient develop seizures while he is on the medication, I start the number 2, and I start to reduce the number 1 slowly and build up the number 2 medication. So basically, it is giving the chance, giving a good dose, and the only thing which stops you, either the patient does not respond or he developed side effect. Now she said that he will be, if it is when you start to switch, I will switch when I give a good dose. For example, carbamazepine 200 milligram, 1/2 is a good dose, and the patient does not still having fits. So I started to add, for example, sodium valproate, depends upon the patient. I am not very quick to change, but I need, it is individualized actually. And the fit itself, it is many varieties. I have patients with very small fits, what we call it mini fit, that just a little bit maybe stirring or maybe clumsing, to the big fit, which is tonic or chronic. These factors must be taken in consideration when we are considering adding or substituting. Thank you.
Thank you. There is a question. Sorry, you had something you wanted to add, Professor?
Yes. One of the comments I want to say in this for this question is sometimes our residents start the midazolam infusion in patient with status epilepticus. The patient was given the IV midazolam first dose and was given the epanutine or liftracetam, and the patient is still seizing after 30 minutes of the infusion, and then they will start the midazolam. They will start the midazolam by infusion, which is wrong. They should give boluses until the convulsions are aborted, and then they will start the infusion. Loading doses, of course, these patients at this time will need intubation and mechanical ventilation. So we give loading doses of 0.2 milligram per kilogram midazolam, for example. I always speak about midazolam because this is our practice in Cairo University. And then we wait between first and second dose 5 minutes before judging, and we repeat until the patient stops seizing. He stops seizure, then we start the midazolam infusion.
Thank you, Professor. This brings me to an interesting question by Al-Jadil, which points, he's asking, what do you do if the EEG normalizes, but the patient is still unconscious after status epilepticus?
The question to me? Oh, okay, Professor, okay, go ahead.
If you allow me, the Professor Siddiq.
Okay, just do.
This is a very difficult question, and this is what in the consensus was called clinical diagnosis of possible non-convulsive status epilepticus. It's a possible because we have given the medication, the EEG improved, and the patient is still comatose, and we explain this that either the dose of the medication was not enough, or the patient is sedated. So we repeat the challenge test after a period of time which is not agreed upon. If we give midazolam injection, so we repeat it after 1 hour, for example. And it's important to differentiate between two types of non-convulsive status epilepticus. This question is more appropriate for the non-convulsive status epilepticus who is not in coma. Who is not in coma. What do I mean by not in coma? As you know, we have the classification of non-convulsive status epilepticus will have two main arms: patient non-convulsive status in coma and patient non-convulsive status without coma. Like, for example, absence status epilepticus. Absence status epilepticus is a patient in non-convulsive status epilepticus. He is not in coma. So if I give him this and his EEG show 3 spike wave discharges, I give him the non-sedating dose of benzo, and then the patient EEG improve and he sleeps and he does not recover, and when he recovers from his sleep he is still confused, I will repeat the benzo if he recovers after 10 minutes, and then I do the interview with him and I find him not to his baseline conscious level, so I will repeat immediately. And this is for all patient in non-convulsive status without coma. In patient with coma, this is not a practical point to deal with, and I will depend on the EEG. I will repeat the EEG so that the drug that I have given in infusion will have walk away, and the effect on the EEG is no longer there, because if the patient was not successfully treated by the trial I have given, the EEG pattern will sure return again after the medication is off. This is a very challenging question and a very challenging area to deal with bedside. And I thank the one who asked this question. This is a very active area of research, and this is and I want to refer him to the one of the lecture of Professor Hirsch on the internet, the managing of non-convulsive status epilepticus.
Thank you so much, Professor. Still 2 questions, I think, directed to you relating to non-convulsive status epilepticus.
Yes.
One from Al-Walchi. What is the most common subtle sign in status epilepticus?
What is the most common?
Subtle sign.
Subtle sign, yes. Subtle
Yeah.
sign. Subtle sign in
non-convulsive
yes.
status epilepticus, yeah.
The terminology of subtle status epilepticus and subtle signs of non-convulsive status has been introduced when patient comes to the ER. He has been in convulsive status, and then he has been given medication, and then there is no more gross motor convulsion, but you see subtle signs like nystagmoid movement in the eyes, gaze to one side, twitching of the eyelids, maybe the thumb will twitch, these are all subtle. Maybe the angle of the mouse will have a very fine tremor or fasciculation, maybe, if you would like to call it that. I emphasize the difficulty in, you must search for these signs, because if you do not search for them, they will go unnoticed. So eye are very important, nystagmoid movement, and sometimes you see the pupil. There is constriction and dilatation in the pupil, which we call epileptic hippus, twitching in the eyelids, twitching at the angle of the mouth, twitching in the thumb, or movement or twitching in the grade 2. Of course, these the thumb and the grade 2, because the cortical localization presentation in the homunculus is wide, and they are more likely to have abnormal activity.
Thank you. Still in relation to that, there is a question from Raza Julien. In non-convulsive status epilepticus, what rhythm of the EEG repetition and criteria do we use to evaluate efficacy of treatment?
A very specific and important question. First of all, we must know the criteria for diagnosing non-convulsive status epilepticus by EEG. There are periodic epileptiform discharges, as I said, that they must be more than 25 in 10 seconds. We count a whole 10 seconds to look for these epileptiform discharges that have certain criteria, or any pattern with definite evolution in frequency, or evolution in location, or in morphology. If these are fulfilled, these diagnose non-convulsive status, or any EEG pattern clinically correlated with a clinical feature of the patient. For example, the patient has a twitching of the eyelid, and with every twitch, you see a sharp wave on the EEG. This is, you must think about non-convulsive status epilepticus. So there is electrographic seizure, and there is electroclinical seizure when you correlate the finding with the clinical features. But if you judge only on the EEG, you must have epileptic discharge at 2.5 hertz or more. This is the main criterion to diagnose non-convulsive status. If you give the medicine and this EEG pattern disappear, and then the patient improve clinically, you start to ask him question, he responds, then you made the diagnosis, the clinical diagnosis of non-convulsive status epilepticus. If the EEG improve but the patient does not improve, you make, and you have these EEG patterns before the giving the medication, then you diagnose probable non-convulsive status epilepticus.
Thank you, Professor. Thank you. We are going to be kind briefly. We have 8 more questions and time is not on our side. There is a question from Nadia Hamza, directed to Dr. Al-Sadiq. For the management of super-refractory status epilepticus, which of the following medication is superior? Thiopentosodium, phenobarbital, propofol, or ketamine?
I would go for propofol, because it's an amazing drug, and the mechanism it works is amazing, many channels. So usually what we do in Libya, we use propofol.
All right. Next question from Akande. What's a useful treatment?
Sorry?
What treatment is useful in that handling of hysterical induced status epilepticus?
This for me, the question.
Yeah, that's for you.
Well, if you are talking about that, it is a hysterical, or what we call psychogenic epilepsy of non-convulsive. Usually the pattern of the epilepsy of the convulsion is a bizarre. You will have hip thrusting, you will have fighting, you will have compacting, you have these things. And of course, if you dig away, you dig in, you will find there is a lot of history of social problems. So usually if the patient is like that, we will give them a diazepam, they will be calling in and they become more, less aggressive. And then we usually cooperate with our psychiatrist. And I have seen many patients, we send them to the in the hospital and they start them sometimes by escitalopram and they will be okay.
All right, thank you. Question from Sofia Sokolov, asking, can epilepsy diagnosis be made in case of repeated seizures in chronic alcoholics?
The question to me.
Yeah.
Yes, yeah. The chronic alcoholic is representing a big problem because if the patient drinks and he go in delirium tremens or you have a subdural, you need first of all to make sure that he has no, as Professor Ihab said, you need to make sure before diagnosing status epilepticus to make sure that there is no other contributing factors. So usually with the CT scan them and look for the infection. But if the patient did not stop and we have evidence on EEG, and so we start them. I usually start by the Kibra because Tigratol is inducing drug, and unfortunately they don't comply and they will come again. So basically, number one, make sure that you are dealing with the real status epilepticus. There is no secondary causes, infection, delirium tremens, subdural hematoma, and then yes, I would start them in the medication, usually Kibra. Yes.
Thank you. Still another question for you from Fernando Melo, however, not well written. He says that in humans, the GABA receptor internalization occurs more widely. And in experimental models, diazepam does not stop status epilepticus after 1 hour, but reduces its severity.
Sorry,
after 5 minutes, after 5 minutes of status epilepticus, does diazepam stop working completely?
Sorry, I didn't get you right. So if I take it right that the gabapentin in the humans, well, if in my lecture I said about the Dr. Cork who stained the GABA receptors on the surface, and after 5 minutes they started to go inside the cell. So what was, hello?
Yes, carry on, please.
So what is the question exactly? What he mentioned about the GABA receptors?
So he's relating that does diazepam stop working after 5 minutes of its use in status epilepticus based on the GABA receptors?
The GABA receptors after 5 minutes, the benzodiazepine is not working. Oh yes, no, what happens, it is not all in the same time. The GABA receptors goes inside the cell gradually. So that is why we have an opportunity gap. It means that when we reach 30 minutes, that's the problem. But before that, still the benzodiazepine will bind to the GABA receptor and stop and make it hyperpolarized and stop the fit. So we are talking about the trouble starts about 5, but reaches the maximum in the 30 minutes. And that's when we talk about supra-refractory or the worst of the worst. Thank you.
All right, thank you. Then when do we give intravenous infusion midazolam in status epilepticus? That's from Carter.
Question to me?
Yeah.
Okay. Well, as the professor said, we don't give an infusion. We started first by the bolus. We give 2 milligrams per kg, and then after 5 minutes we add, and then we do the infusion, not the way around. And of course, there must be the patient is intubated, and hemodynamically we are keeping an eye on his blood pressure because it will cause hypotension, and then we start that. Okay.
Thank you. And then another question from Walchi. How do we deal with our psychiatric patients on antipsychotic drugs who come in with status epilepticus? That's directed to Professor. And what's the best choice of the anti-seizure drug?
Is this directed to me or to the professor?
Yeah, directed to you.
Okay. The psychiatric medication will not differ in managing status epilepticus, except that you should be aware of the QT interval, because these drugs have the propensity of prolonging the QT interval. And when you give drugs like lacosamide, not favorable in this patient population because of the QT interval. You just follow the status epilepticus guidelines like any other status epilepticus. It does not have a special situation except that the point of QT interval prolongation with psychiatric or antipsychotic drugs, and these patients also are more prone to non-convulsive and more prone to hypotension. This is the only area that or only points that will differ in this patient other than the general management of status epilepticus. I would like to have a small comment on the timing of medication, because in most guidelines, and I think Professor Siddiq will agree with me, that we have first line drug, which is the benzo, and then we wait for the response. This is most of the society guidelines. Wait for the response before giving the IV anti-epileptic drugs like phenytoin or levetiracetam or lacosamide. This is my personal experience. My personal experience is that I don't wait. I always tell the resident, do not wait. Why waiting? In certain guidelines, they tell you that you give the IV benzo and then you wait. If the patient, if the status stops and was aborted, you don't give anything else, which I disagree, because if you don't give something else, the status might return at a later date. That's why when I say first line and second line anti-epileptic drugs in status epilepticus, I always say first line, which is the benzo, and first line also which is the anti-epileptic drug, because you need to buy time. The benzo are good for aborting the status, but the anti-epileptic drugs, the IV anti-epileptic are good for prevention of recurrence of status, especially if you do not know yet what is the pathophysiology underlying the problem. I don't know, Professor Siddiq will agree with me in this.
Yes, absolutely, Professor. Yes, this is the same view we take here. We give together because we want to, time is brain. That's the, that's the key issue of it.
Yes.
Thank you so much. We have two more questions and we wrap up. One is asking if a patient is on levetiracetam or phenobarbital orally, is the loading dose decreased? I think it's asking if he gets status epilepticus and he has been on these drugs. Do you decrease the dose? On if the patient is on levetiracetam, that's Keppra, or phenobarbital orally, is the loading dose decreased?
The question to me.
Me or Professor Siddiq?
Whoever feels like.
Go ahead, Professor.
It's open.
I think there is no time to, I think, being aggressive, especially with anti-epileptic drugs. For example, if the patient, while the tiracetam, even phenytoin, if the patient is on phenytoin, I load the patient as if he has never taken phenytoin before. Why I would be anxious about getting the patient on the side of toxicity to terminate the status? I will give a full dose irrespective of the patient, because I don't have feedback about the compliance. Yes, I know that the patient is on anti-epileptic drug, but I will deal with him as if he is not taking any drug.
All right, thank you. I think it's well taken. Any comment on autoimmune epilepsy? Just a question about autoimmune epilepsy in adults and frontotemporal treatment. Anything about autoimmune epilepsy? It has been coming up in the new world.
I can, if Norse is what you mean, Professor Martin, the new onset refractory seizure epilepticus, which most of them turn out to be autoimmune. I think according to different literature, 60 to 70%. The pulse steroids and acute immunomodulatory or immune therapy like plasmapheresis and or IVIG will be the best management in this patient until the result of the labs, if available, will set in.
Thank you.
Welcome.
We have the last question. Walsh is asking about what's the general approach of pregnant woman in status epilepticus. I think it's still the general management regarding, but you can expound on that.
Yes, well, there is two schools. The gynecologist like magnesium sulfate, and the neurologist like the diazepam and the phenytoin and all these things. Being me as a neurologist, adult neurologist, I usually use the usual guidelines, starting by the lorazepam or diazepam and phenytoin and etc. But in the end of the day, I don't think there will be much difference between magnesium sulfate and the benzodiazepines.
Thank you so much.
You're welcome.
Our expert presenters and panelists. And I want to thank the audience so much for their time and endurance and my sincere appreciation for their time given to us from 8 up to coming to 10 East African time, around about in Libya and Egypt. But we are so happy that you've endured with us. And this brings us to the end of our live session.
Thank you, Professor Martin. Thank you, Professor Sadiq. I enjoyed tonight being with you.
Thank you, Professor Rehab, and enjoyed talking to you. And so, Professor Martin, I was happy to share with you, and really it was very enjoyable session. Time fly, and see you next time, inshallah.
Inshallah.
Thank you so much. Have a nice weekend.
Bye-bye.
Inshallah.
Bye-bye. Bye.
Bye.